Okay. Take it away, Dr. Badran.
All right, so good afternoon, everybody. I am Dorgam Badran, and I'm going to talk about shock today. Obviously, it's a very huge topic, but we will go through some important things, about it. All right, so let's see. Go next on this one. All right, so shock, right? So what's the definition of shock? So shock is a life-threatening condition of circulatory failure. It is a state of cellular tissue hypoxia caused by inadequate oxygen delivery that is unable to meet the cellular metabolic needs and oxygen consumption requirements. So the effects of shock are initially reversible, but can rapidly become irreversible, resulting in multi-organ failure and death. So septic shock accounts for 2/3 of all shocks. And we know, like, usually we use the word septic shock for when the pressure is below 65, the MAP pressure is below 65 or the systolic below 90 and not responsive to fluid administration with a lactate above 2. Or there's a sign of end organ dysfunction. For some reason that slide did not show up.
Dana,
here.
can you hear? Okay.
Yeah. So what are the categories of shock? Yeah, I think that's the one. Yeah. So that's the definition that we talked about. So it's like very, what's going on here? We have some technical issues.
Sorry, my phone was controlling it. Yeah.
Okay, all right. So yeah, this slide for some reason went up here. Okay, so the categories of shock, we have, actually this is what we're going to talk about today. Sorry about that, guys. So we're going to talk about the definition of shock, shock categories, shock management, some special situations. We mentioned the definition of shock, and you can find a lot of ways to define it, but it's mostly like, lack of oxygen delivery to the tissue, right? And does not say hypotension per se, right? Sometimes you can have shock with a normal blood pressure. There's a lot of kind of shock that does that. And the effect of shock, you want to prevent it to become irreversible, right? So the categories are mainly, there's obstructive shock, tamponade pneumothorax or tension pneumothorax, PE, congenital heart disease. There's a hypovolemic, hemorrhage, fluid loss, burns, cardiogenic, and there's a neurogenic shock, distributive shock, which is sepsis, anaphylaxis, drug ingestion, and dissociative shock. Do you remember what's dissociative shock? So that's when the hemoglobin is attached to the oxygen and doesn't let go, right? In some of carbon monoxide toxicity, they call it dissociative shock. So here's a table that you can see the different characteristics by the type of shock and management. There's example of each one and what happened with the heart rate, blood pressure, cardiac output, and they still talk about capillary refill. That's still very important in evaluating the shock, or extremity temperature, and the SVR and the treatment. Now, management will mostly depend on the etiology, right? And then how acute are the symptoms and how the patient is deteriorating. The main goal would be to identify shock etiology in a timely fashion and to treat it properly to prevent rapid deterioration and end organ damage. So there is a line you don't want to cross, which is a line of irreversibility. Well, imminent death. Once you identify the etiology and start treatment, the war is not over, right? So you need to stay put at bedside. So when we started, right, don't leave the patient bedside until you see some improvement or stability. Have frequent evaluations, we have the sepsis evaluation, I have it there, Paul, 3-hour, 6-hour evaluation in sepsis, which will be less frequent intervals if rapidly deteriorating. So don't assume like just starting a pressor or giving fluid and then just like go sit down somewhere else. Like stay next to the patient until you see some improvement, some stability, because these things you need to work on like right away. Keep assessing the patient end organ perfusion, vital signs, hemodynamics, and trajectory of clinical condition. Because you need to know what's the next step. What if my fluid challenge doesn't work? What if my pressor does not work? What's next, in this management? You don't want to keep it, because every hour counts, right? I mean, every hour counts in terms of perfusion to all the organs, brain, liver, kidneys, etc. So I will talk about some things related to septic shock and pressors use. So there is this literature article or narrative review. It's called "The Timing of Vasoactive Agents and Corticosteroid Initiation in Septic Shock." So this is a narrative review in the Amar et al., in the Annals of Intensive Care, 2022. And in here, they did some adjustments. You might need to use your loop for this one, But they did some adjustment, some recommendations for gaps in the sepsis and septic shock recommendations. And in here, on the left side, it says like how the catecholamine vasopressors, as a first-line treatment or agent is norepinephrine. And they have epinephrine as the second-line treatment, if you don't respond to norepinephrine and vasopressin. So first levo, then then vaso, then epi, right? But interestingly, like after they reviewed some more literature after this 2021 Surviving Sepsis Campaign guidelines, they suggested some changes to it. So they said that you should initiate norepinephrine within the first hour of hypotension during or after adequate volume resuscitation. Consider vasopressor initiation after receiving a fluid volume of at least 2 liters. Well, we have some exceptions to that. Initiate epinephrine at a norepinephrine dose of 0.5 to 1.7 mics per kilo per minute, which is like a huge dose, right? 37 to 133 mics per minute. And avoid delaying epinephrine beyond 133 mics per minute. Hopefully we never reach that, right? But that's obviously the recommendation here. Now, the second one is when to start the non-catecholamine vasopressors, right? Like vasopressin. So here, in the original 2021 guidelines, they suggested it at 0.25 to 0.5 mics per kilo. But then they saw that there is more benefit toward using it earlier on. So the recommendation became as initiate vasopressin at a dose of 0.1 to 0.2 mics per kilo per minute, which is equivalent to 10 to 15 mics per minute, and avoid delaying starting it if norepinephrine is above 0.3 mics per minute, which is like 25 mics per minute. And they also add the angiotensin 2, initiating at a norepinephrine dose of 0.2 to 0.3. I never tried that before. I mean, I don't think we have it. It's called Giapreza. That's one of the drugs that they use, angiotensin 2, and it's basically just going to squeeze the, the smooth muscle of the vessels. And apparently it does work. In addition to vasopressin, within 3 hours from shock onset. And then the last one is about corticosteroids. There's a lot of confounding, articles. I think there's a huge 4 randomized clinical trials, and 2 of them showed, improvement, like in terms of mortality, and 2 did not show improvement. But then all of them showed less time of shock. So there's still the recommendation is to start a low-dose hydrocortisone, stress steroids. And here they say initiate within 24 hours, and norepinephrine dose of 0.5 to 1 mic, which is like, I think, a high dose, 40 to 80 mics per minute. Luckily, we don't wait this long, but again, that's the recommendation there. Let's see what's... So vasopressin, right? So the Surviving Sepsis Campaign 2021 suggested using vasopressin guided by how fast your requirements increase. But usually, they recommended starting from 0.25 to 0.5. Now, this review in 2022 suggested to start it earlier, as we mentioned, from 0.1 to 0.2, 10 to 15 mics per minute, and don't delay it above 0.3. There is a vast trial that, showed that adding vasopressin to norepinephrine decreased mortality mainly when levophed dose was below 15 mics. Meaning, like, if you wait too long when the levophed is above 15 or let's say 20, 25 mics, they saw that the benefit is lower in terms of mortality, versus starting it earlier on. Yes, there were a few studies not showing survival benefit from vasopressin addition, but to norepinephrine, but many others showed a significant link with mortality. So there was a benefit to mortality. I add like 2 more of those articles. And this one, this is a 2022 study. You see what's the name of it up here is Gorsi et al. Critical care. So they show like 2 kinds of patients. There's some patients who have, there's a pattern of how fast the levophed or the process requirements go. Like this is levophed, and they call it in refractory shock. These are the people who just, after a few hours, you just see the levophed requirement skyrocket. And there are other people who, have something called controlled shock, which is steady and controlled rise of vasopressors. And this is where the good outcomes is. This is bad outcomes. They saw that, they think at this time where the dose of norepinephrine is at 0.5 mics, that's when things start either getting worse into refractory mode or getting better into a control mode. And that's why they suggest using vasopressin at this dose, right? And that's like probably where they went with for the 2021, studies. But again, afterward reviews suggested even starting vasopressin at a lower rate here, like 0.1 to 0.2, seeing that helped, decrease the amount of levophed and also improve the mortality. Now, this study here is called Early Administration of Multiple Vasopressors is associated with better survival in patients with sepsis. And this is a propensity score weighted study. This was also done in, was posted in 2023 in the European Journal of Medical Research. So the conclusion of this study showed that the timing of secondary vasopressor administration is strongly associated with the outcomes of patients with sepsis. And this is like a 1,400 patients. And here you can see that there's an early group and there's a normal group. So early, like starting multiple vasopressors early on, basically improve survival with a good power. Okay, and then you can see here like the 28-day mortality and in-hospital mortality. It was statistically significant as well, in terms of early group versus normal group. There was, a decrease in mortality in these patients. They did not see much change in terms of AKI in 7 days after vasopressor use between the early group and normal group. That's something to mention here. And this is another graph showing that this is the mortality adjusted hazard ratio and norepinephrine dose when adding second vasopressor. So they see here, this is 0.1 of levophed, 0.2 of levophed, and then when you start vasopressin around here, that's how you can decrease their mortality by starting it earlier than later on. If you started, like, let's say at 0.4, you'll be having higher mortality. If you started at 0.5, you have even higher mortality. So they suggested to started, like that reviews that happen afterward. They suggest like the earlier you start that second vasopressor, you have a higher chance of decreasing that curve of mortality. This is another study in 2022, association of catecholamine dose, lactate, and shock duration at vasopressin initiation with mortality in patient with septic shock. So they concluded that higher norepinephrine equivalent dose at vasopressin initiation and higher lactate concentration at vasopressin initiation was each associated with higher in-hospital mortality in patients with septic shock who received vasopressin. So this is kind of the conclusion there. Mortality increases by 20% for every 10 mics per minute increase in norepinephrine when adding the vasopressin. No change after 60 mics per minute. So after 60 mics per minute, there's no really much difference. Also, there was a link between adding vaso when lactate is higher with a higher mortality. So don't wait until the lactate is so high to start vasopressin, or when the norepinephrine is really high. So again, early multiple vasopressors, right, has shown improved mortality outcomes in septic shock versus increasing a single agent like norepinephrine. And these are the reasons that they suggest in the article. There are variable receptors, sensitivity and expression to different pressors. Thus, each one work on a different receptor. Complementary actions. So some, pressors add to the other, right? So they complement each other in terms of how they work. There is a less catecholamine base pressors, right? So there are some link between decreased catecholamine use and decreased side effects of heart rate, arrhythmias, cardiac, issues as well. And apparently, that also decreases from that catecholamine pressors use when you use a vasopressin, for example, or another pressor. Although might have more adverse effects, like to have more than one pressor. One pressor might work better than another for the same patient, depending on the genotype, sensitivity, organ-specific downregulation, and receptors expression of that patient. So sometimes, there's no one rule for them, right? So sometimes you try one pressor and then it does not work, try another, but don't run away. Don't say it's not working. Just keep attacking it until hopefully you find the right pressor for the patient or inotrope. Now, early pressors within 1 hour of shock and fluid administration showed better outcomes. And that's where people starting to give some fluid in the ED and then start pressors early on. We know that improves the outcomes. Steroids is still debatable, as we mentioned, but did decrease the time of shock. So we have been using it. High-dose thiamine improved lactate clearance, in certain patients. It's very helpful. Well, I hope you look like this when you beat shock. I'll give you a few hints. Yes, he seems very happy there. I know. Now, early detection of septic cardiomyopathy or cardiogenic shock is a key, as mortality is very high in this group of patients. Well, let's get septic. Keep an eye on how much fluids you give, right? There are exceptions for the 30 cc per kilo rule. We've been using, luckily, ideal body weight, or we can use that, right? Probably only applicable in very few septic patients that you can give the whole amount. We get a lot of sick patients these days, and they have all kinds of diseases, renal failure, liver failure. If you give them that amount of fluid, hopefully they already have pressors on, but if you do, just be vigilant. What kind of fluids you give? NS, LR, albumin, right? So there are obviously studies, showing pros and cons of all these fluids. You can see in cardiac surgery, we use a lot of albumins, there's not much evidence behind it, but it does decrease the amount of crystalloids you give. So if you give it if you give the albumin, give it understanding that you don't have to give as much crystalloids in patients who are heart failure, liver failure, or renal failure. It does help in those cases. In sepsis, I don't think it's not good for sepsis. Usually the, LR and NS are better choices. The only problem with normal saline is it can increase your hypochloremic metabolic acidosis. So that's something to keep an eye, especially when you have renal failure as well. So that's like too much acidosis to deal with. And on top of that, lactic acidosis. So there's a lot of, acidosis issues that happen with the kind of fluid you give. So pick the right antibiotics, go broad spectrum initially and escalate as it goes. Start Levophed and vasopressin early on. I usually start Levophed early to ensure the MAP is above 65 first. Start vasopressin when Levophed is around 10 to 15 mics per minute. That's my approach. Consider starting steroids, high-dose thiamine. Stay put next to the patient. Don't leave your spot. Like if you want to get something from this lecture, is just try not to move away from the patient until you see some kind of improvement, like you see some change in the hemodynamics. It's because like sometimes, you just go and then either it's get lost, like the nurse gets busy, you don't get a response, and then you go back and then you try to start over with the patient. It's hard to bring them back. Like there's a very fine line for that irreversible line, so you don't want to pass that line. So if things are not improvement, right? You do levo, you do vaso, and then like, okay, so what's going on? Why are we still going up on levophed? Well, there's next steps. So look at the echo. Make sure there's no, cardiomyopathy. There's no like, heart failure in there. There's no RV dysfunction. There's no tamponade. Repeat the chest X-ray. It doesn't mean that the X-ray was fine like since the morning, that it's better now. So you can look at the X-ray, look how wet is the lungs. Maybe they're wet. Maybe there's an effusion that you want to have. Maybe there's a pneumothorax. So these are the things that you can be a little generous in doing, and then they might assist you if the patient is deteriorating. Do I need an inotrope, right? Depending on that echo, or deal with an obstructive shock, right? Do I need to do something about the tamponade, the pneumothorax? Do I need more fluids, right? So you can look at the IVC, give a fluid challenge. You don't have to go crazy and give a liter. Give 250, give to 500, The fluid channel is 250, right? 250. Give it, see if there's an improvement. Sometimes you have to give better, especially in the low EF states, But if you have a normal EF, you can give more than that, What's going on with my lactate? So this is how often I check patient in shock. Mostly they are cardiogenic, shock, but I'm wondering why not doing it also in sepsis or other kind of shock? Why not? Like, what's the downside of that? Why not checking the lactate every 3 hours, make sure that the trend is right? Why not checking CMP every 6 hours? LFTs really can, change. Like, the older method of doing it, they say, oh, you just do it daily because it takes a long time for LFTs to change, but not in shock. In shock, the liver is very sensitive to perfusion. So actually, you can see changes every 6 hours. In the LFT, especially if somebody is a dialysis patient. So CMP won't go wrong because you still can check the LFTs. If both are getting worse, well, too bad. It's like you're not doing well. No bueno, right? ABG is Q4, right? So that's something I also do. Why? Sometimes when I have somebody who's not doing very well, okay, let's check a blood gas with lights. Let's see like what's going on with the electrolytes, with the ionized calcium. I've seen ionized calcium in a lower side. I give like some calcium chloride or calcium gluconate repleted, keep it closer to 5, I would say, and then it did help a lot with the contractility. It did help a lot with the pressure requirements. And I was able to wean a lot of times pressors and inotropes just because I repleted calcium. The ABG, right? So look at the acidosis. I mean, this is also voodoo, some people say treat the pH that is like below 7.2, 7.1, right? Because that's more related to the hypotension that you get, with the smooth muscle dysfunction and dilation. But, again, if you want to have a number to go by, I go by a bicarb. Bicarb is below 20 and the patient is on low pressors, give a bicarb, if there is no contraindication, and, like sometimes when, at that time, maybe patient is renal, maybe patient is lactic acidosis, maybe whatever reason the acidosis is, I feel like it's important to keep that bicarb within reason. Why? Because sometimes you see the patient at the level of, they are trying to compensate, right? So the pH is normal, but the pH is the bicarb is 16, but they're blowing it all off, like hyperventilating, right? And then, why think about that? Think about that like you're trying to help them have less work of breathing, right? So you give them the bicarb, you replete that, and you hopefully decrease the consumption of oxygen that they are consuming, right? Because you want every single oxygen drop, to go to the organs. Do they need blood, right? Blood transfusion. Because again, it's all about the perfusion. And the crit, right? It's hard to know what crit is good, right? But usually, 24 is okay, especially in shock states. If you want to go higher than that, in very certain cases where they are actively bleeding, yes, it makes sense to go above that to 28 maybe, but 24 I think, is reasonable in shock states, okay? Not for regular transfusion. Now, victory belongs to the most persevering. I cannot read who said it, but yes, Bonaparte, yes.
He did well.
Yeah, he did very good job. He did not have victory, he did. So, not much, right?
Not in the end.
Yeah.
The history books.
That's right, that's right. Now, the SWAN showed mortality benefits in patients with cardiogenic shock. There's a lot of articles regarding a SWAN, and it did show, mortality difference with the shock. It helps manage patient in a timely manner and preventing patient from getting into refractory cardiogenic shock. We call it extremis in the ABCDE, Society of Cardiac Angiography, something shock stages, right? So we're going to talk about that next. Now, SWAN has very low risk in general, okay? So it does cause heart block, from 1 to 4%. So I put 4% because it's just the highest of the percentage. So 1 to 4% can cause a heart block, especially if you have like a left bundle. If you put the SWAN, it usually causes a right bundle. And then you can go to a complete heart block. So sometimes people say like it's kind of like relatively contraindicated if you have a bad bundle to start. Just make sure that you have some pads on, or like a transvenous spacer close by, or transcutaneous spacer. I don't know, but it's a risk, and it does happen. It did happen before. Sometimes you just have to remove the SWAN when you're floating it, and it just resolves. But sometimes it does not. But a lot of times you just pull back. Like if you get those arrhythmias, bad block, pull it back. Don't keep it, and then maybe try to put a pacer first, a transvenous spacer, before you go back and try to float it. PA perforation is very rare, but it does happen. I mean, 1 in 1,000. The issue is with the SWAN is a limited use, right? So in the last decade, it's down 50%. So it's not going up with the use of the SWAN. Like it's going down. And that's why a lot of people are not comfortable using a SWAN, because it's hard to interpret the numbers. Like if you don't know how to interpret the numbers, it's hard to use it. Like you're just going to deal with the complication of the SWAN, but not with the benefit of it, right? So that Society of Cardiovascular Angiography and Interventions uses a 5-stage system to define the severity of cardiogenic shock. So there's stage A, B, C, D, and E, and that's how you're going to see it sometimes in some textbooks. And technically, stage A, which is the bottom of the pyramid right here, it's at-risk patients, patient at risk. They have some comorbidities, they're starting to get septic or whatever, hypotensive. Stage B is the beginning of shock. Stage C is a classic shock where you start, start getting hypoperfusion, being on pressors, inotropes. And then you consider mechanical support at this stage in stage C. In stage D is deteriorating, which is like escalating in mechanical support. And stage E is the extremis or multi-organ failure or maximum mechanical support. That's stage E that you don't want to reach because it's very hard to come back from. Usually in this state is where we need the ECMO, because there's a lot of multi-organ failure, a lot of process requirements, and really there's no way to perfuse all the organs with just a single device like an Impella. These are the things that we can do as mechanical support. CP Impella to the left ventricle is only up to 3.5 liters of flow. RP Impella for the right ventricle. 5.5 Impella for the left ventricle gives you up to 6 liters sometimes of cardiac output. VA ECMO, and we have ECPella, which is ECMO and Impella together. Usually we save those for people who have issues with the right ventricle and oxygenation maybe, and also left heart failure. So that's why you need, both sides, you know, and also you need the impella to vent the ventricle, in terms of ECMO patients. That's why we use that. But that's a different topic. RV dysfunction is often missed and is associated with higher mortality if not managed well. Escalation of support is guided every 6 hours in cardiogenic shock. So that's the question. Why not similar frequency in sepsis patients? Why just the 3 and 6 hours? Why not just keep doing it every 6 hours, and just keep assessing the patient? Like, what do we have to lose if you do an extra blood test or just come to the bedside or ask about the patient who was in a very bad shock? Like, let's not just go home at 5 or 6 and then come back in the morning and then like, what happened? Why the pressure is like this? So unless you see improvement, you should not stop asking about the patient. Yes, we have people following here at night, but again, you have to give them also some kind of guidelines, like what to do next. So you started this pressor to go down on this pressor. You started this inotrope to go down this inotrope. What are you watching? So give them a little plan for the night, so then overnight, if things don't go as planned, they will call you. But if they don't get any sign out regarding this patient, what do you expect is going to happen? Nothing. They're just going to keep the map beautiful, and then in the morning, it's just going to be looking not great. The LFT in the morning is going to be 6,000, and then comfort care next. So inotrope selection is important. It's very hard to titrate inotropes and presses sometimes without a swan. Or you have an alternative, frequent bedside echoes. But how frequently you're going to do the echoes, right? How good you are looking at the echoes. So that's an alternative. If you're not comfortable doing a swan, it's fine, but do an echo at least to give you an assessment. If you have a central line, check the CVP, transduce the CVP. So at least you have some information there, right? You can have some cardiac output information and some CVP information, from there.
The central line, you can also check a gas, and your SAT will be pretty close to what a swan will be. It'll be off by 8%. But if you check the central vein, it's called SCVO2, and it's like 30%, it's similar to a swan. It'll be correlating quite closely.
Yeah, if it's too low, yes, it does correlate close, but it's not very accurate, obviously, because you still have to go through the RV, and there's also a mixture coming from the top too and the bottom. The CVP depending where it's coming from, right? But the RV, like the swan number, the SVO2, or the mixed venous gas, it comes from both upper and lower, right? So SVC and IVC. But when you put, a central line, it's just gonna take it from wherever it is. If it's a little high, it's gonna take mostly the top and not the bottom. So the more accurate number is from both the lower limbs and the upper body, to give you an idea how much left of oxygen in the PA after it's extracted in the body.
So just put the central line all the way into the range, right?
Yes, you can. Yes, you can put that central line in the PA, as Paul said. Sure. Good luck with that.
Still balloon.
Yes. So this is something good, like to try to stay here, hopefully, and prevent deterioration. It's like really shock is about prevention of getting here. Like we try to see who are these people, at risk. What can we do to improve them? Like this is like probably severe sepsis, right here, beginning. B, severe sepsis. Here, patients who are septic. So if you don't treat them right away, they're gonna go into C very soon, And then this is mostly for cardiogenic guys, okay? This is not sepsis related. This is more cardiogenic. And then in terms of, there is an algorithm that I recommend you guys to read regarding cardiogenic shock. And that's in the same article there. So if you suspect a patient with cardiogenic shock, so you need to identify cardiogenic shock. Systolic blood pressure below 90 for more than 30 minutes, or the use of inotrope vasopressor to maintain systolic blood pressure. Evidence of end organ hypoperfusion or lactate level above 2. So that's a clinical criteria to rapidly identify shock state. That's how we identify it. Activate the shock team, call critical care, transfer patient to the ICU, If acutely decompensating heart failure, cardiogenic shock is suspected, that's when you get an echo and get a right heart cath. If acute MI or cardiogenic shock from MI suspected, well, you need a right heart cath, go to the cath lab, get revascularized, assessment of peripheral vascular anatomy too at the same time. Why? Because if things are not going the right direction in the cath lab, the nice thing when they do the cath, they look at the limbs, they look at the arteries of the legs. So they know if they are actually adequate to put mechanical support, like a balloon pump or an impella or ECMO, whatever. So hemodynamic criteria for cardiogenic shock. So cardiac index below 1.8 without inotropes or vasopressors, or above 2 or below 2.2 with inotropes and vasopressors, or the wedge pressure above 15, or the cardiac power output less than 0.6 with a PAPI less than 1. Cardiac power output, do you remember that one? Which is the cardiac output times the MAP divided, right, on 451. That's a CPO. Less than 0.6, cardiac, cardiac shock. PAPI, which is a pulmonary artery pulsatility index, should be above 1, right? So if it's below 1, there's a problem. So that's systolic PA minus diastolic PA divided on CVP. So if hemodynamic criteria are met, consider mechanical support. And then when we talk mechanical support, well, it depends on what the needs of the patients are. Usually if it's left-sided failure, we go for an impella. Sometimes they do balloon. But the balloon pump is mainly beneficial in coronary artery disease, like ischemia from coronary artery disease. It improves the perfusion of the coronaries. That's the main use. But they're using it off-label for cardiogenic shock. They're using it for a lot of MR. It does help offload a little bit there. But ideally, impella, left-sided. And then if the RV is failing, maybe RP impella, right? But a lot of times these patients are also hypoxic, and there are a lot of edema. They're hypoxic, and they will need some oxygenating help. That's where ECMO comes into play. And when you are on VA ECMO, for example, in these cases, you need to keep them venting the left ventricle. Okay, if you don't do, it gets distended, and it does not help the left ventricle relax. You don't want to tense that ventricle. You want to offload it so it can heal appropriately. And there is a concept there called reverse remodeling. Because after an MI, you get into that phase of you doing like the bad remodeling, right? That's where angiotensin inhibitors comes into play, ACE inhibitors. And apparently they showed that using a VAD, long-term VADs, but in general, like it does help offload that ventricle and help that left ventricle recover and prevent that scarring of the left ventricle from happening. And thus it causes something called reverse remodeling, but that usually takes like a long time, like 3 months, and sometimes up to a year in durable VADs. So that right now we're keeping the impella, sometimes the 5.5 for 6 weeks just of label, to rehab patients. There's no yet evidence about it, but we had 2 patients that we successfully removed the 5.5 after 6 weeks, and they were able to walk around the unit with the impella still in. So for some reason, like it did help them a little bit, through it, but obviously there are risks for keeping it above. Now the recommendation for cardiogenic shock is to keep it, the 5.5 is 2 weeks, 10 to 14 days to show improved, outcome. After that, it showed no improvement in terms of like, no change in the outcomes. That's for acute cardiogenic shock. The CP impella, which is the one that they put in the cath lab sometimes, is supposed to stay there, for 24 hours, up to 4 days maximum. Sometimes we had it for longer. The main problem with those that they had the pigtail at the end, you have to keep them heparinized and they clot very often. So some special situations, so we can wrap up. What about severe aortic stenosis? So severe aortic stenosis with sepsis, right? People, this one is very hard to manage, right? Because you are losing the battle in 2 fields. The cardiac output is low because the aortic stenosis, right? It's not allowing the flow to go. And the SVR is low in sepsis. So if there's a cardiac arrest, I'm telling you, they rarely come back, very rare. So hopefully we can prevent the cardiac arrest from happening in this kind of patients. So that's why it's important to have an echo in people who are getting worse in sepsis. You know, make sure that they don't have like low EF state or severe valvular disease. Norepinephrine is still a drug of choice in these patients. Inotropes with a normal EF, you know, they might get worsening that gradient of the aortic stenosis. So usually they don't like to have high contractility. Unless the EF is very low. Ensure adequate fluid, right? So in aortic stenosis, we all learned that you need to keep the heart full and avoid tachycardia, right? Slower heart rate and, you know, full. If low EF state might need gentle inotropy, but it reaches shock state. But if we reach the shock state, we might need, like if the patient is shocky, you know, at that time, like lactate start going up, LFT is going up, there is no solution to severe aortic stenosis but to do an emergency balloon valvuloplasty. So they go to the cath lab, they open that thing. The issue with that sometimes they cause a lot of AI, then you have to put an impella to keep draining that ventricle. You know, so that's why BAV alone could work, but you know, sometimes they have to put the impella as well until they get a TAVR during the admission, etc. So that's the way to do it. SWAN would be very helpful in these cases because then it will give you like what's the volume, what's the SPR, what's the cardiac index. So these are the information you can get from a SWAN in these patients and how to titrate your things. Now, how about severe MR? Now, this one is tough due to risk of pulmonary edema, right? And flooding the lungs. That's what happened with severe MR. We get a lot of these patients, you know, you put the echo, oh, severe MR. Really very tough to deal with. Usually avoiding bradycardia in these patients is important, and volume overload. It's opposite to aortic stenosis.
In both of these situations, are you saying severe AS with sepsis and severe MR with sepsis, or is this just like shock?
This is separate now, severe MR. But I believe that it's important to know it, you know, with or without sepsis. You know, the left side is like, yeah, I mean, that's first sentence. It's a scary method, scary thing that I don't want to see, you know. Somebody with severe aortic stenosis going under anesthesia. Okay, it's the same thing. Like you dilate them. Once you dilate them for any reason, you give them any hypotensive drug for these patients, they will tumble down, you know, and it's very hard to bring them back. You know, not only in sepsis, any vasodilatory effect.
I guess I thought the first choice for severe AS was phenylephrine.
That's, yeah.
Propensity for tachycardia. Is that not the case anymore?
So, well, that's probably that's me, norepinephrine.
Wow.
You know, because like I see a lot of patients would have like, you know, some kind of cardiac issues, you know, like either they have, you know, low diastolic dysfunction or low EF or etc. You know, but yes, we use phenylephrine all the time in the OR. You know, mainly in these severe aortic stenosis, like for example in the cath lab, but they rarely have normal valves. Like the other valves are rarely normal. You know, they have some issues there. So I feel like Levophed has the main squeeze that you want from phenylephrine and still gives you that beta 1 that helps if you have other things going on. You know, that's my feeling about Levophed. You know, now yes, phenylephrine is a great choice if you are sure that the patient EF is normal. It's fine. You can start with fluid, start with you know, phenylephrine, but don't abuse the phenylephrine. You know, because you can go high on it. That's too high. Sometimes I see like 200 mics. There's something wrong there, right? There's something missing in these cases. And the problem with that, like sometimes it squeezes a lot of the organs, and I'm worried about shock state, you know, where you have phenylephrine squeezing everything down. Like it's almost like you have, you know, like vasopressin or epi, like a high dose pressor, you know, without fixing the problem. You know, that's my thought about it. You know, that's why I choose it over phenylephrine a lot of times. You know, unless the patient is like great patient, you know, coming for an elective surgery. You know, but in the ICU, I rarely use phenylephrine, like rare.
When I looked at this because the PCU was using it, and the 40 mics per minute of phenylephrine is 0.02 of Levophed. It is homeopathic. So even running 200 mics is not a lot, and you're of like catecholamic equivalent, and you're running a lot of volume because it's not that concentrated. So I think, you know, like pure afterload is technically the textbook answer, but you're right. Like a lot of our patients are going to have some LV dysfunction or whatever, I think the big thing would be if, like he's saying, if they're tachycardic or if they're in AFib, that's where you have a huge problem. And that's where the catecholamiine is going to drive that. So that's where I was going to ask you, like early vaso, if you think this is truly septic shock, and that's where the Swan can help you. It's like early vaso might be better in these guys because you're getting a little more afterload than the catecholamiine.
I completely
Once
agree.
these guys flip into AFib and they're doing like 130, 140, they're spiraling big time. So whatever it takes to get them out of that.
I completely agree. So some cases, like you cannot use it. Anything that has AFib, or tachycardia, you better use that. Vasopressin, low dose, that's fine. And that's where like it comes like, you see a lot of people like you start Levofed, it's like at 0.2, 0.3 Levofed, 0.4. So you're going to be tachycardic for sure, so why not start vaso earlier on, and wait for that tachycardia. What else? So Swan is also very good, especially with the low EF state, right, with the severe MR. It's not accurate sometimes, when you usually the accuracy, like, it's not accurate with severe TR, okay, because that's not going to be reading it adequately, but severe MR still should be adequate. In ruptured papillary muscle, right, if you have something like that and severe MR, they require emergent open heart surgery to fix it. In other cases, as temporizing method, they put an impella to offload that ventricle and help with the MR. If you have a lot of MR, you can put an impella as a treatment in some kinds of shock. All right, last slide. So AMI, cardiogenic shock, acute coronary syndrome, cath lab, emergency, cardiac surgery. We talked about impella, ECMO. Comfort care is still okay, right? In some cases, like let's be reasonable. Sometimes unfortunately we get those patients and we refer them to cardiac surgery or cardiology, like right away, like they're 89 years old and previously, like why are you calling for a cath, So be reasonable there. Acute RV dysfunction with severe respiratory failure, right? Something that happens very often, right? So severe pulmonary hypertension could be the reason related to that lung disease or as a primary pulmonary hypertension. Hypoxic pulmonary vasoconstriction from severe hypoxemia, right? And causing RV dysfunction. I see good result with the dobutamine drip in these cases, especially if they're morbidly obese. For some reason, it does help, okay? I don't know why, but it does help a lot. Help the RV and also like dilate a little bit pulmonary.
Are you a believer in vaso not affecting the pulmonary pressure much?
Yes. Also, vasopressin does not cause as much pulmonary vasoconstriction. So yes, I am a believer. I forgot to put it there. Perfect. I will add it. So vasopressin and dobutamine. Inhaled Flolan is useful in these cases of floating the RV and improving oxygenation. Although we know that it didn't improve mortality as much, but it did help your oxygenation. In a lot of cases, it was used. But mainly you use it in the cardiac unit to help the RV function and come off ECMO or come off RP impella. We have used it many times, but if you have like severe lung disease, why not try it? Just trial them, like it's not much just to try it. Try to titrate epi down as soon as you can. That's the second thing I wanted you to remember from this lecture. I feel like epi is just a monster, and I hate it so much. You probably know already. Titrate epi with Flolan, with dobutamine, or Merlunan if the pressure tolerates, right? Sometimes the pressure doesn't tolerate that. Why you're trying to avoid bowel, leg ischemia, and persistent lactic acidosis. You get a lot of lactic acidosis, and you wonder why the lactic acid is not coming down. It's because of the epi. In a lot of cases, not all of them, but a lot of cases, that's the case.
I saw just that we had a patient the other week. I think you might have consulted them for mechanical support, but this guy was on levovaso epi, and you would have thought the epi at a decent dose was giving contractility because there's a lot of was biventricular dysfunction. But as soon as we put dobutamine on, all three pressors came off, which is crazy because you thought, oh, you're on epi, but the contractility you got from dobutamine, and that was all this guy needed. He needed nothing else, and 3 high-dose pressors came off within 2 hours.
So that's good. So just tell you, like, try try something different, because like at some point there's either a tachyphylaxis, or again, as we mentioned before, the receptors are not responding. Maybe because the epi is causing a lot of lactic acid, or maybe it's like the tachycardia involved. Maybe the catecholamine dose is too high, you know. So yeah, I feel like a lot of times I came off like very high doses of inotropes with dobutamine, you know, more than Merlinon. Because sometimes when you do Merlinon at that phase of multi-organ failure, they're acidotic and they're very dilated, so they don't like Merlinon, you know. Dobutamine, for some reason, it does not affect your dilation as much, you know. Still can cause vasodilation in certain cases. Now, also fix the lungs, right? Try to really fix the lungs. Sometimes you have those RV failures or, you know, cardiomyopathy related to hypoxia and hypercarbia, right? So aggressive ventilation management, recruitment, bronchodilators, bronchoscopies, paralyze the patient, fluid removal, avoid getting the patient very overloaded. That's really gonna hurt, you know, the heart. It's like they are both combined together. You're like, it's like a one system, you know, cardiopulmonary, right? So they just like depend on each other. If you make them like go to 8-10 liters positive, you know, it's just going to be very hard to come back from that. And that's when they get hypoxic to the point of requiring the ECMO, you know. And that's not sometimes the solution in certain patients, you know. Like we need to try to fix them before they get there, because it is, you know, a last modality that we want to use in patients because of the high risk, very high risk, you know, with this kind of mechanical support. Now, CRT can cause hypocalcemia, remember that as well. And, you know, I used, you know, calcium chloride in a lot of cases, of gluconate, and it did help a lot. You know, one time I put a calcium drip and came down from 40 mics of epi, you know. It's like, you know, yes, when I stopped the calcium chloride, you know, pressure went down again, but it did help come off something, you know, like epi, like that high dose. But don't do that, you know. Don't wait until it's too late. When multi-organ failure starts, call for help, call other providers, you know, early on. Multidisciplinary approach is okay, is the way to go. There is no pride in losing a patient to the nasty shock. Right? And that's it. Thank you, guys.
Wow.
Hey, can you hear me?
Thank you. Any questions?
Can you guys hear me? Can you guys hear me?
So like dobutamine instead of epi? Yeah, sometimes mostly with RV failure. Like you have somebody who is not hypotensive and they are not, like, you know, they are in the beginning of getting very bad, you know, sick, try dobutamine. You know, sometimes we use it for people who are bradycardic and they have like bad MR, you know, although they can go into AFib, yes, but it does help the function of the heart, you know, and then improve the contractility in these patients, you know, like somebody who has like a very bad bradycardia can help with the dobutamine, right? But I've seen people in early shock state loving the dobutamine, and usually at 5 mics. When you go to 7.5 and 10, that's kind of like too much, yeah.
It's interesting. So at SCCM, they talked a lot about, they had a lecture on like beta blockers and sepsis, and that's kind of been emerging. It's not, I don't think it's ready at all for regular use, but the concept is really on this like catecholamine sparing thing, which I don't feel like we learned that in training at all. But I'm kind of talking with the CD folks, I started becoming being more aware of that, and that's where the idea behind the vasopressin, even the angiotensin, is coming into play. It's that there is actual a lot of harm of having so much catecholamine for a long time. Even yes, you're getting your pressors up, but like some of the things they talk about, literally you get a form of immunosuppression from all the catecholamine because it's going to affect so many different genes. They talk about metabolic dysfunction, actually more coagulation activation, so like clotting, worsening cardiomyopathy, even things like sleep, right? People are on like essentially adrenaline. Their sleep gets screwed up, they get more delirious. So I'm starting to become a believer in whether it's the early vaso and maybe one day they'll have angiotensin around too. Let alone the cardiac world where the heart is injured and you're trying to whip it with more adrenaline and
It's true.
People don't do too well.
Yeah, that's a very good.
For septic shock, the new SCCM guideline has like a conditional recommendation for dobutamine as like a third pressor.
Oh yeah.
Like Levo, Vaso, and then for some patients where they are suspected like a septic heart, doing dobutamine.
But they have to have, you have to, I think you have to see something on the echo, though,
Yeah.
right? Either low EF or RV. If they have a normal LV, you might make things worse, or you might
That's
make them-
true, but I think it's like constantly with a septic heart, septic cardiomyopathy is suspected.
Yeah. I think like a lot of time we miss the RV. The RV is missed a lot.
It's not
Like-
reported.
Yes, it's not reported. So look at the echo yourself. Look how squeezing it is. You know, that's something I would recommend. Just make sure you look at the echo with your eyes.
And it might
you know.
change from when it was done
Yeah.
2 days ago. Right?
But yes, I agree with the vasopressin for pulmonary hypertension cases. It's very important, you know, as an alternative to, you know, Levophed or Neo. You know, it does not cause as much vasoconstriction in these cases. Yeah.
There was a little pop-up thing from Dana that said, hey, can you hear me? I told him no. I texted him no, but
Sorry, you guys can't hear me.
Do you have any questions for anybody on the lecture? Maybe write it down somewhere.
Yeah, Dana, can you type it up? Or call us.
Well, we have headphones on, so there's no, our speaker side here.
Jess,
I like your hat, by the way, Dana. You know, looks good.
Our audio is sent to headphones, it's not speaker.
Contractility. Lidocaine. Yes, yes, please. Too much lidocaine is not good. Okay, if you go to CVICU, you will see a lot of lidocaine hovering around. I agree with you, Dana. You know, like, so the recommendation for lidocaine drip and VTAC, right? You know, is usually start at 1 milligram per minute. You know, sometimes they go up to 2 milligram per minute, which is fine. You can do that if the patient does not have heart failure, liver failure, and renal failure, and that's like almost like rare. You know, when we started in these patients, because they get lidocaine toxicity, and lidocaine, yes, does worsen your contractility and getting into the toxicity. Toxicity starts with nervous system into the heart. And then what's the treatment for local anesthesia toxicity? Lipid emulsion, which is intralipid, right? Intralipid. And hopefully you don't have to use it. But one time, because Zoe would not go down that lidocaine, I had to bring it bedside, you know, just to keep it next to the patient. The patient cannot, and usually we use the intralipid when they go into arrest refractory to ACLS. Like, you know, and in those cases, you need to use epi and a very lower dose. Like, you know, in the newer guidelines, right, of ACLS, you need to use 100 mics of epi instead of 1 milligram of epi and local anesthesia toxicity, okay? Or we can say 1 milligram per kilogram, no, 1 mic per kilogram of epinephrine in these cases. Otherwise, you might get more toxicity, you know, from that. So yes, lidocaine, I hope never use 2 for these kind of patients, which is like 90% of the times. If you use 2 milligrams, fine, use it, but lower it as soon as you can, or check lidocaine level every hour, which is almost impossible to do, you know. And the toxicity level is what? You guys remember? What's toxic level of lidocaine? Is 5, right? 5, you know. And they usually say 5, but it's typically a little bit more than that, but it's just to scare people off, you know. Usually it's 7, you know. All right, very good. Thank you, everybody.
Thank you.
Have a good day.